This is Conversation Balloons, a podcast of interviews with experts and friends about all things generational. I'm your host, Leah Farish. Today we're addressing a controversial and sensitive topic, and you might keep that in mind if you have children in the room who might be listening. Use your own judgment on where this should be shared, but we do hope you will share it because it's an important conversation. We are hosting Dr. Julia Mason, who is a board-certified pediatrician and fellow of the American Academy of Pediatrics. She is a board member of SEGM, the Society for Evidence-Based Gender Medicine, and a clinical advisor as well to GenSpect. She has a busy practice in Oregon at this time, and we're just very indebted to her research, the speaking that she does to professional associations and the public, and we thank you very much for coming on, Dr. Mason. Well, we have an interest in starting out with just your own practice in pediatrics. We want to know how your patients are doing. Who are the kids who are seeking gender affirming care? What do they need? And those who are getting it, how are they doing?
Okay, so I've been a pediatrician for coming up on 30 years. I was training back in the early 90s, and I never saw a patient, a transgender patient, or a patient with gender dysphoria until about, I think, 7 or 8 years ago. And then I had a young woman come in and tell me that she had always felt that she was actually a boy. And she had a really cute story about when she was a little toddler and told people, no, really, I'm a boy. And they said, well, if you're a boy, then where is your penis? And she had one of those belly buttons that stuck out. So she would point to her little outie belly button and say, that's it, that's my penis. And, that's an adorable story. And I said, oh, transgender, that is a thing. I have heard of that. There is a clinic over at the Children's Hospital. I can refer you there and they will help you out. And they went over to the clinic at the Children's Hospital and came back a little distraught saying, oh my God, testosterone, it's a shot and I hate needles and I can't give myself a shot. And I said, that's okay. You can just bring the medicine here and we'll administer the medicine. We can't charge for it, but it's fine. Just come in and, we'll give you the medicine. We ended up teaching his grandmother. He was living with his grandmother, how to administer the medication. And he went on to, masculinize. But what I noticed with that patient and then with multiple other patients was he didn't seem to do the tasks of adolescence. I tell my young adult patients that adolescence is a time when you need to do hard things to set yourself up for the rest of your life. Maybe you need to go to college, maybe you need to learn a trade, maybe you need to start a business, something. You're putting in hard work because you're young and strong, and then it's going to take care of you for the rest of your life. This patient didn't go to college, didn't learn a trade, was just working one minimum wage after another. And he had ADHD, so I was seeing him 4 times a year at least, and just didn't seem to be thriving. And then I had a couple more patients. Now, full disclosure, I had one patient who came in with their mother saying, I'm trans, and I really didn't see it. But, they were there with their mother and they're like, I'm trans and I need a referral. So I gave the referral, and I thought this person was going to be told at the gender clinic, you're not really trans, you've got something else going on. But nope.
Mm.
This is when I started to look into it. All patients are affirmed. There is no
Mhm.
treatment other than affirmation. And so this patient was also affirmed and had a double mastectomy after they graduated high school and before they started college. So I do have one trans patient who has started college. And I saw him one time after he'd started college, and he was just joking about how they all had the same voice, all of these young women who were taking testosterone.
Mhm.
But that was one, and most of them were like the first patient I described. They're sort of consumed with being trans and not moving on with their life.
Mm.
I
Mhm.
have friends my age who are gay, and I can remember my friend complaining about young men who, in the 80s, they were just consumed by being gay and they weren't doing anything.
Mm.
So some
That's
people get caught up in
unfortunate.
identity.
Yeah. Oh, and that's certainly being encouraged, apparently. Um, well, we, of course, hear that the danger, if they're not affirmed in their quest as even prepubertal kids,
Hmm.
that there's a danger of suicide. Is
Yeah.
there any correlation in the research with a
Yeah,
denial of this care
that's
and
a really
suicide?
important part, because it is said over and over that medicalization of children with gender dysphoria is life-saving care. And
Right.
if you look into the literature, you can find studies who document decreases in suicidal ideation,
Mm-hmm.
um, but you can't find anything that documents a decrease in completed suicides. Now, part of
Mm.
that is because suicide is thankfully a very rare occurrence, and it's hard to do statistics on very rare occurrences. But Michael Biggs is a professor at Oxford. He's a sociologist. And he did a Freedom of Information Act request from the Tavistock Clinic, which is the world's largest gender clinic in
Mm.
North London, England. And he got data on almost 15,000 patients. And in those 15,000 patients, there were 4 completed suicides.
Mm.
2 of them were of patients who were on the waiting list. And that's one of the big problems with the Tavistock Clinic, is they got overwhelmed with patients and then people were on the waiting list for years. And
Mm.
2 of them were being treated.
Mm.
So, I mean, I can't say definitively, see, there's no difference because the numbers are too small. But
Mm.
4 out of 15,000 is about, I looked this up, it's about twice, 2 to 3, it's about twice the background rate for kids in that age group.
Mm.
So I guess, but the most recently published big long-term, and I put long-term in quotes, long-term follow-up study of young people getting medicalized in the United States was, it's called Chen et al.
Mhm.
2023. It was published in the New England Journal of Medicine. And this is an NIH funded study. And so, in order to apply for the NIH money, they needed to say what they planned to do.
Mhm.
Um, it's a multi-million dollar study, and it's in multiple gender clinics. Theoretically, the best gender care in the country. And in this first publication in the New England Journal of Medicine, they said the most common adverse effect of their treatment was suicidal ideation. And they had
Oh.
2 suicides in
Mm.
315 patients.
Oh my
And
goodness.
that is a horrific suicide rate.
Mm.
That's 50 times the background um, level of suicide in this age
Oh.
group. So there's not any good evidence that shows that medicalizing kids is a life-saving treatment, because the kids, especially the adolescents, they tend to come into this via the internet, via their friends and via the internet, and they are inculcated into this mindset, that the reason I'm unhappy, the reason that my life is not as good as I think it should be, is because I'm actually a boy trapped in a girl's body, or I'm actually a girl trapped in a boy's body. And that explains everything. And if I could just change that, then I'll be a new person and my life will be better. And if I
Mm.
can't change that, I will be suicidal. Like, suicide is part of the culture. They tell each other that being trapped in the wrong body is unbearable and makes you
And
feel
something to commit
suicidal.
suicide about. Mhm.
Yes, it is a thing. It's actually amazing that we don't have more suicides, given how much they talk about it. It's like it's against everything I've ever learned about suicide prevention as a
Mm.
pediatrician, 30 years ago.
Do you think in the process of assessment uh, that the ideas actually introduced to kids
I don't think that in the process of assessment it's introduced. I think the kids walk into the clinic already having heard about that.
from
The kids
social
walk,
media?
yeah, from social media, from their friends. Yeah.
That's so unfortunate.
Yeah, because
Well,
I
go ahead.
really feel like the gender clinic doctors, they see themselves as life-saving heroes. They
Mhm.
hear this talk, the kids come in
Mm.
saying they're suicidal, and then they give them the testosterone, and the kids are like, I'm so happy I'm not suicidal anymore. And they're like, wow, I'm a life-saving hero. But none of them are collecting the data. This has been done to kids for more than 10 years. We should have long-term follow-up data. It
Mm.
appears that regret tends to take 7 to 8 years to set in.
Oh my.
And so any study that's like, yeah, we followed them up for 18 months, you're still in the honeymoon period. You don't know how it's going to go.
Right, and with testosterone, the first few doses really bring exhilaration in a lot of patients and
Yes,
a feeling
testosterone
of
is an
euphoria.
anabolic steroid. It makes you feel good. It makes you feel strong. It gives you a lot of energy. It makes you very horny. Um,
At
it's a
least at first.
powerful, yeah, at first, it's a powerful medication. It's a powerful drug.
So cut off a penis, save a life, right?
Invert a penis, save a life. Yeah, yeah.
Oh. Well, let me help the audience understand the steps, the stages of treatment on a minor when they go through
Hmm.
the entire protocol. So
Sure.
it starts with the assessment and maybe a counseling. Do you find that they're getting an adequate amount of that sort of help
No,
at that stage?
no, they are not. They are not. The original papers that described pediatric transition are known as the Dutch protocol, and they were published in 2011 and 2014. And in that protocol, they were saying to themselves, wow, our transsexual patients are just not happy. They're not doing well, even though we try so hard to make them look like the opposite sex. Maybe what we need to do is transition them sooner. And it's pretty obvious they had men in mind, because once a male has passed through puberty, it's really hard, to get them to pass as female. So maybe what we need to do is stop their puberty. That was the thought they had. And so they tried to find young people who were what they call true positives. So they were looking for young people who had maintained a cross sex identity from the age of 2 or 3, like the patient I mentioned first,
Mhm.
pretending that
Mhm.
her belly button was her penis. And they told the families of those patients, do not change the name, do not change the pronouns. You know, you tell your
Mhm.
child you are a boy. Don't tell your child he's a girl. Tell your child you are a boy who wants to be a girl. And when you're older, the doctors can do some things to help you appear more like a girl. But they did not talk to these kids about having their sex changed. They
Mm-hmm.
really didn't want to introduce that idea, because if you have a child that's less than 8 years old, they're going to believe that the
Mm-hmm.
doctors can do such a thing. So in the initial paper, the way they described it, they were very careful to say, don't do the social transition. Don't tell the kid that they really are the opposite sex. And then they wanted to have the kids move into puberty for a while, because they knew from past research, and we have decades of research on this, that 66 to 88% of kids with a cross-gender identification will desist when they hit puberty. And the classic is the very effeminate boy who is drawn to dolls and pink and skirts. And when he's told, you can't have those things are for girls, then he responds, well, then I'm a girl, because that's toddler logic, right? And that boy, wants to hang out with the girls, wants to do the girly things, but then he hits puberty and testosterone shows up, and he gets a crush on his gym teacher, and he figures out that he's gay. That's just the stereotype. But a supermajority of these kids would desist when they hit puberty, and a majority of them turned out to be gay. So the Dutch knew that. They knew the data. So they didn't want to do anything to these kids until they had some puberty.
Mm-hmm.
And then the ones that persisted, they're like, all right, these kids have persisted their entire childhood and into puberty. These are the ones. And then they proceeded to do all their stuff, which consists of puberty blockers, and those are GnRH agonists, gonadin releasing hormone agonists. It's kind of a weird thing, but it basically, at the level of the hypothalamus, blocks all sex hormones. And we all have a little bit of both.
Mm-hmm.
Males have some estrogen, females have some testosterone. It blocks them all. It is chemical castration. The medication was developed for prostate cancer, right? Because prostate cancer is a cancer that responds to sex hormones, like it grows in response to sex hormones. So they're like, okay, you have a cancer. We're going to wipe out all the sex hormones so your cancer doesn't grow. There's
Mm-hmm.
some breast cancers that are also, sex hormone sensitive. So they gave them these puberty blockers that were designed for, they were devised for prostate cancer, used for chemical castration of adult sex offenders, and also used for abnormally early puberty.
Mm-hmm.
So this is when,
Precocious
thank you,
puberty.
I've blanked on the word. Yeah, precocious puberty. And when, as a pediatrician, well, I've never actually had a patient with precocious puberty that required treatment with puberty blockers, to show you how rare that is. I've been a pediatrician almost 30 years. I've seen
Wow.
thousands of kids, and I've never had a kid who needed a puberty blocker for that reason.
Mm-hmm.
But if you read about it, you're putting the puberty blocker, because it's often an implant that goes in the arm and it's there for 2 years. You're putting it into a girl's arm at age 5 or 6, and then
Mm-hmm.
removing it 2 years later. And so if you put it in the girl's arm at 5, because she looks like she's, heading into puberty at age 5, then it removes at 7. She'll probably start her periods at 8. And that's a year early, because the normal range for starting your periods is 9 to 17. But that's what was recommended. It's like, well, but the side effects are so extreme. That's what you do. Or like you put it in at 6 and you remove it at 8.
Now,
Yeah.
let's talk a little bit about some of the effects on other systems when you use puberty blockers, like bones, brain
Mhm.
fog.
Right,
What
right.
else?
So if you put in puberty blockers, you wipe out all of the sex hormones, and they act on more than just the sex organs. They are important, like you said, for the development of bone. I'm a pediatrician. I do a lot more x-rays than adult doctors, because kids have softer bones. So if a kid sprains their ankle, we get an x-ray to make sure they didn't break something. So
Mm-hmm.
kids have softer bones because they are growing. And then in adolescence, the growth plates close and the bones start to get a lot more dense. And if you put a kid on puberty blockers, this does not happen. There was a case that became well known in Sweden of a child that goes by Leo who was put on puberty blockers and developed spinal fractures and is now in constant pain because they have these spinal fractures, a thing that you see in, much, much, much older people. That is not a thing that should be happening to a teenager. And what really concerns me is if you have, say, a 12-year-old girl who goes to the gender clinic and says, I'm actually a boy, and they say, okay, our first step is puberty blockers, and she's already started her period, you are going to put her into menopause immediately. She's going to go through menopause in
at
like
age
a week.
8 or
at
9?
age 12. No, at age 12.
At age 12. Okay.
And she's going to go through it in a week. And all the things that you might remember. So yeah, brain fog, definitely. Hot flashes, all that stuff. And the puberty blockers seem to cause depression in a not insignificant number of children because they're just wiped out if all of their sex hormones are removed from their body. So the first step these days, if you don't follow the Dutch protocol, is social transition. And people are doing social transition to very young children. And I think this is a big mistake, but this is happening all over the country.
And what's involved in social transition?
Social transition is simple. It's just you allow this boy child to grow his hair out. You give him a new name. You dress him in girl clothes, and you go to kindergarten and say, this is Jane, and she's a girl. And that is happening all over the Western world right now. And I find that particularly tragic because a child of that age, a child of 5 or 6, any child young enough to really believe in Santa Claus, is going to think that it's actually possible to change your sex. And that it's all, and it's all fun and games until puberty shows up. And then you get into the serious medications with the serious side effects.
And of course, you have sterilization, which I want to talk with a little bit later in context of informed consent. But let's go on to, if you feel through talking about cross-sex hormones for purposes of this interview, how about surgery? Talk to us about
So the puberty blocker is followed by cross-sex hormones, and that would be testosterone injections or topical gel for the females and estrogen injections for the males. Taking large doses of estrogen orally is toxic to the liver. There are young men out there doing that because birth control pills have estrogen in them and they can acquire those. But that's really not recommended. So anyway, the cross-sex hormones have a lot of effects, some of which are reversible, but most of which are permanent. And so estrogen will make a male grow breasts, and testosterone will make a female's voice deepen, her Adam's apple become prominent, and she'll get body hair and facial hair and start losing the hair on her head if she has anybody in her family who lost their hair, because I was told that hair loss is on the X chromosome, which is why if a guy is trying to figure out if he's going to lose his hair, he has to look at his mom's family, not his dad. Yeah. So, but if you're female, you have 2 X chromosomes, so you have twice the chance for hair loss. And that doesn't reverse. So you start off on the.
I was hearing a young woman who wanted to desist from the transition saying, I knew that I was getting my breasts removed, but I still had wide hips. It's like no one ever talked to her about you can't change that surgically or chemically.
Exactly. And you can't change your hands. And men's and
Mm.
women's hands are very different. So, right, so there's the cross-sex hormones, and then there's the surgeries. And the most common surgery being done on children is breast removal. And breast removal is being done on kids as young as 12.
Mm.
Um, and it's considered, gender affirming care. And it's a chest masculinization surgery. They remove the breasts completely, and then they bring the skin from the top of the breast down, and you end up with these incisions. And then they cut the nipple from the breast, and they basically abrade the skin where they want to put the nipple, and they often trim it to make it smaller. And they just really, really scrape and abrade the skin where they want it to go, and then they just stick it on there. And
Mm.
it usually will take, but sometimes they don't take. Sometimes they fall off.
Oh
But
dear.
they have no sensation, and they don't function,
Sure.
but you get a more masculine looking chest. The results may vary. It depends on who you are underneath there, and how much
Yeah.
weightlifting you do, etc. So
Can
that's
you
the most
talk a
common.
minute?
Yeah. Mhm.
Can you talk a minute about binders before that?
Right. So before that, girls will use binders, and these can vary a lot. Some people will literally like wrap their chest in duct tape, which is terrible. There are binders you can buy that have like very stiff fabric in the front. So they're sort of a sports bra, but with a very stiff piece of fabric in the front to try to flatten the breasts. Um, these are not these are not healthy because they inhibit your ability to breathe.
Mm.
A girl who is wearing a binder is gonna not be able to participate in sports. She's not gonna be able to run. She's gonna have a hard time just going up the stairs.
I've
It's
read
a
that it can affect your back, your spinal
Yes.
development.
I think it can affect your back, and I've talked to multiple detransitioners who say that they have dents in their ribs, that they
Mhm.
actually deformed their rib cage because
Oh
they
dear.
wore the binder so
Oh,
much. And
okay.
so mastectomy is the surgery most commonly performed on kids.
Mhm.
Genital surgeries do happen on minors. Jazz Jennings is a pretty famous example. Jazz was 17 when they did an orchiectomy, so that's a castration, removal of the testicles, and a vaginoplasty, and that's where you create an opening in the pelvis and you invert the penis to try to be the vaginal lining. The glands, the end of the penis, the bell end of the penis is placed in front of this new pseudo vagina to try to be sort of like a clitoris. But what happened with Jazz is what's happening with a lot of young people these days. Jazz was blocked at the very beginning of puberty,
Mhm.
and so Jazz's penis did not grow because testosterone makes the penis grow. The first sign of puberty is the testicles enlarge, and then the second sign of puberty is the penis enlarges. Well, as
Mhm.
soon as they saw his testicles enlarging, they put him on a puberty blocker. So he had a tiny boy penis, and that is not enough material to line a vagina. So then they took material from his gut to put in there,
Mhm.
and then it didn't work well, and he had to have multiple surgeries. And in the original Dutch protocol, one of the 55 final patients died from an infection, and the infection was because of this. The penis was too small. They tried to use some colon to line the new vagina. There were germs, and the patient had sepsis
Oh my
and
gosh,
died.
that's horrible.
And that's
Um,
a pretty high mortality rate for what is essentially a psychological and cosmetic treatment.
People who undergo at least the cross-sex hormone stage, if not the surgical stage, are they able to have sexual pleasure? Are they able to orgasm?
Right. It's variable. I mean, there's definitely some trans people insisting, that their life is awesome. But we have videotape of Marcy Bowers, and Marcy Bowers was Jazz Jennings' surgeon. She is a trans woman, and she has done probably more vaginoplasties than any other surgeon in the United States.
Mhm.
And she's in it's a video of a Zoom meeting, so it looks like the Brady Bunch with all the little, all the little squares and the people in them.
Mm.
And she says that of her patients who were blocked at the very beginning of puberty, just about none of them are able to have an orgasm. They are anorgasmic,
Oh,
and that is lifelong. And jazz
that's
seems to fit into that category. They talk about it in the TV show.
right. Are you aware of any possible tissue transfer or market for these organs that are removed, which might be desired by other people, especially if the person undergoing the first surgery wants to be non-binary and doesn't have an interest in retaining a penis?
Right, right. That is a new thing. I don't know much about that. Luckily, that has not moved into pediatric medicine, but there are surgeons who offer nullo surgery where they kind of make you look like a Barbie doll, and there's nothing there. And I saw a
Mm.
really sad little paragraph written by a woman who had gotten the surgery, and she was quite clearly saying, "Now I can't be raped."
Oh,
Um, but organ transplantation is really complicated, and so I think that's more in the realm of science fiction. I don't think that's a thing that's going to be happening
yeah.
anytime soon.
Well, one thing that made me think of it was finding out that there was some tissue trade in the abortion world in fetal body parts that we hadn't really accounted for. We don't want this to get commercialized beyond how much it is.
Well, it is commercialized because in the United States, the Obamacare is being interpreted to say that insurance companies have to cover gender affirming care.
Mhm.
And the insurance companies, you would think they wouldn't want to do it, but basically they take that into their calculations, they raise their rates, and they make profit off of every dollar. So if the medical market is bigger, that ends up being better for them. Um,
So there is tax money going for these procedures and protocols for such like the military and other
yes,
programs, and then we
yes.
pay for it privately through private insurance
There
as
was an
well.
interesting study published fairly recently that looked at military, like military medical expenditures that showed a 30% um, desistance or detransition rate.
Oh my
30%
goodness.
of the patients were stopping. Now,
Is that covered by insurance also
oh
or
no,
by tax money?
that's really interesting. Detransition doesn't have any diagnosis codes. There is no
Mm.
diagnosis code for detransition. I mean,
And that means,
it means that it's hard to treat a patient who is detransitioning because
and
we
it's
can't
hard if you
call
can't
it.
code it, you can't get paid.
Right. If you can't code it, you can't get paid.
Could that
And
be a reason why there's so much resistance to publicizing people who are detransitioning?
perhaps I think the resistance is because, for one thing, Lisa Littman did a good study of detransitioners, and 75% of them said they had not gone back to their doctor to
Hmm.
say, hey, as it turns out, this was all a big mistake.
Mhm.
And I think that it's a difficult thing to do that. And, these are not happy people, right? Like, if everything's going great in your life, you don't look to a difficult medical path to become a new person, right? These are the kids who have troubles, and it's all sorts of troubles. Seems like a lot of times with the girls, it's undiagnosed autism.
Mm.
They're on the autistic spectrum, but it's much less common to diagnose a girl with autism. And so they're just struggling. They're just struggling socially. They're missing social cues. They're not doing well in girl society. And then when they find out that maybe that it's because they're a boy, it all makes sense. If you're a girl
And
with
they
autism and
and
you look at
thus
this, it makes sense.
and if they're put on the freight train to medicalization, a lot of this help they miss out on a more holistic approach to their conditions.
Yes, yes. What I'm
Um,
worried about is that right now they aren't getting counseling. They aren't getting exploration of possible reasons why they want this. It's just as soon as they say it, then it's just accepted and you move on from there. They call it affirmation only. And it was my professional organization, the American Academy of Pediatrics, who put out a statement in 2018 saying that affirmation is the only acceptable way to respond to a child who expresses a cross sex identity.
that makes me think of the hearing that was held recently where Representative Crenshaw in the Congress asked Dr. Meredith McNamara to cite studies in support of medicalization of these minors, and she couldn't do it. And
Mm-mm.
she did say it's just the standard of care, and
Right.
that's a legal term,
Yes.
um, but and it's a pretty conclusive legal term. It's very protective of the professionals who invoke it, but unfortunately, we need more empirical basis for that standard of care that we're not getting.
Right. Well, that's the thing. We've got WPATH, right? It was the Harry Benjamin Society. Harry Benjamin was a quack, but anyway, they renamed themselves WPATH, the World Professional Association for Transgender Health. And I like to say they identify as a professional organization.
Oh,
And they put out they have been putting out these things they call standards of care, although if they get pulled into a courtroom they will say it's not a standard of care, but they publish it and it says standard of care on the top. And the most
mhm.
recent one came out recently, and it's SOC 8. And I got a look at it before it was released late last year, and I thought to myself, if this eunuch chapter stays, then I'll know that they have been taken over by the activists. And it did. They kept the eunuch chapter. So they literally have a chapter in their standards of care about people who identify as eunuchs and
Hmm.
how to give them medical care to help them in their self-identification as a eunuch. And in the chapter, it links to a website which is a fetish site.
Oh,
It's
gosh.
full of I deeply regret clicking the link, but it's full of basically text porn about young men being castrated against their will.
Oh, my.
Yeah. And if you study men who say I identify as a eunuch, the vast majority of them were repeatedly threatened with castration when they were kids. That's how the idea got in their head.
Oh, my. Well,
Um,
let me, yeah, pursue this idea of this, what some call social contagion, or how it does get in
yeah.
kids' heads. It's been called a mass hysteria, which I find an interesting term since hysteria is
Hysteria.
related to the etymological root of the word womb. Um,
Right.
but I recall a novel in the 1800s by Goethe, The Sorrows of Young Werther, which details a moody young man who is a romantic, the quintessential romantic who uh, is depressed and brooding, and eventually, and he loves to wear a yellow jacket, and he eventually commits suicide. And there was a spate of suicides in Germany after that,
Hmm.
and also yellow jackets became quite fashionable.
Right? Yeah,
I
we
shouldn't laugh because
no,
this
but
is a
we are a
tragic
mimetic species.
thing.
That's what we do. We're a social species, and we take cues from the people around us about what's the right thing to do, which is, yeah, the experience with that book was one of the things that informed sort of modern standards around suicide. When Kurt Cobain, the lead singer for Nirvana, killed
Mhm,
himself,
mhm.
they tried very hard not to glorify it, because they knew that he was a public figure, and that if they really went on and on about
Popular
it,
with kids.
yeah, that he would inspire a lot of copycat suicides. And I feel like they did pretty well with that. But then just a few years later with Robin Williams, it seems like we'd forgotten everything. I think social media just let the cat out of the bag. Like, and
Mm.
so the journalists are like, well, it's already out there, and so, uh, but I've got videotape that I took with my little iPhone at the AAP national meeting last fall of a gender doctor glorifying the suicide of a trans identified boy. She
Oh,
said she boldly ended her life.
oh,
And then
heroic,
later on,
huh?
she's, yeah, and then she used the word boldly again. She said boldly stepped in front of a truck. And I'm just sitting there like,
Oh,
oh my God, surely somebody's gonna like stand up and say, what are you doing? But of course nobody did. Everybody just
oh.
sat there. Um, it's
Well, let me
really, yeah.
c- bring up a study you have mentioned elsewhere, but just briefly, as
Mhm.
Hakim's experience with the group therapy, with combining
Oh yeah,
people who are considering transitioning with those who were at the time called transsexuals,
right.
who were they were not. This group was not formed to address the trans uh, experience per se,
Uh-huh.
but tell what he found from
Right. So
this.
Az Hakim is a psychiatrist in England, and he took an interest in transsexuals, and he was put in charge of like group therapy. So he was supposed to provide group therapy, because this is the National Institute. This is a National Health Service in England, and group therapy is more economical than one-on-one. So they're like, you need to do group therapy with these people, and he had the brilliant idea of doing a combination with pre-op and post-op transsexuals. So these were all men. These were all men who thought that they would be happier if they could live as women. And they were, some of them had gone through the surgery, and some of them had not. Now, obviously, any transsexual who had gone through the surgery and then felt very happy was not going to be coming once a week to the clinic for group therapy. But
Admittedly.
it's still notable that of the preoperative transsexuals who were in his group therapy, just the exposure to people who had gone that much further down the path and who still had issues.
Hmm.
It's like that old phrase, wherever you go, there you are. you know
Hmm.
so just the exposure to the fact that you could have the surgery and still have problems made 90% of them decide not to go ahead with the surgery.
Incredible.
Yeah, yeah.
Let me
Wisdom from the
talk with you a
past.
little bit about, as an attorney myself, there's some five things I want to hit with you fairly
Mhm.
briefly. I noticed that sterilization, which happens with the ultimate transition process, has been ruled cruel and unusual punishment in some courts, and uh, is certainly not supported as a punishment um, for a crime. It may be used as a prevention
Mhm.
for future crimes in some cases, but um, it seem rather odd that we're allowing children to choose something which has been prohibited
Yeah,
for
right. as cruel and
adults,
unusual
even in
punishment.
cases where the convicted person may agree to it. So it isn't always allowed.
Oh, wow. Yeah, no, it's just a phrase I use a lot is we live in the upside down. Like, I just feel like so many things have gone crazy about this. I don't think it makes sense. I don't think that trans is the new gay. I think that a lot of this can be explained by the conception that, like you say, okay, someone is gay and they are just gay. They were born that way. That's the way it is. And I think that's true for the most part. I mean, I think it's a spectrum and things are complicated and blah, blah, blah. But a lot of people who are gay, they're just gay. They didn't choose it. But I do not think that the same can be said for everybody who is telling us right now that they are trans. And is it possible that 2 out of 10,000 are these, mythical unicorn true trans kids? Maybe, but I don't think that what we're doing now has any justification. There are way too many false positives right now. Even if such a thing exists, and I'm not entirely sure it does, we can't be applying these heavy-handed treatments onto thousands of kids on the basis of what they tell us.
And I've read that the strenuousness or the passion with which a patient um, says that they're trans or wants medicalization does not correlate with their satisfaction later.
Oh, definitely. That's just a personality trait, you know.
Okay, yeah.
There are
Yep, yep.
laconic people and there are intense people. And
Yeah.
I would say the intensity with which they insist this is the only solution, that's when my skepticism gets stronger.
Mhm. And that's true with the scientific literature that you've said that was what bothered you early on in questioning this whole process. That what was it, 99% of those who
Right. One of my first red flags when I started having more and more trans kids and I was looking into it was that everybody from the endocrine attending at the children's hospital to the trans woman who ran a youth group for quote trans kids close quote told me that 99+% of kids who are put onto these puberty blockers
Mhm.
continue onto the cross-sex hormones and the surgeries and the rest of it. And then they'd look at me like, see? Like, see? That means
Uh-huh.
the kids they know, they just know. And I'm like, no, that is not what that means. That means that your puberty blockers are not a harmless pause. That means that the puberty blockers are concretizing what could have been a temporary cross-sex identification in the before times, before we did the social transitions, before we did the puberty blockers, 70 to 88% of kids desisted on their own. But
Could you
now
could
the
you
numbers are
say that
reversing.
again? Could you
Right.
say that
So
again for me?
in the original data, in the before times, I think it's 67 to 88% of kids who had a cross-sex identification would desist with the onset of puberty. And then a small
So we're
number
doing
would
some kind of
continue.
intervention to change those numbers, aren't we?
Definitely. If you socially transition a kid, you are locking in that identity.
Oh,
There
go
was the
ahead.
most affecting interview of a woman who is, she's a lesbian. She has a wife. They have 2 kids. And their older boy was sort of a classic, very soft and effeminate and, liked the girl stuff. And then he said that he was a girl and they were all in. They were like, yeah, okay, we have a trans kid. Wow, now what do we do? And they did a social transition. They changed his name, they grew out his hair, they put his clothes on. But then 2 years later, his little brother, who had had no signs of like being effeminate, who was just a classic boy, rough and tumble boy's boy, says, "I'm a girl too." And then they're like, "Wait, what? You're a girl too? No, you're definitely not a girl." But then all of the people who had been so like enthusiastically supporting them in their social transition of the older boy were like, "Hey, if he says he's a girl, he's a girl." They weren't
Yeah, you've
willing
locked yourself in.
they weren't willing to, they weren't willing to accept any kind of nuance here. They're like, "You accepted the one trans girl. Now you just have to accept that you have two trans girls."
Oh
And then
my
these women
goodness.
are like, "No, no, 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 no. Wait a second. No, like it made sense with the first one, but it does not make sense." And so then they did more reading, and then they discovered people who, were outside of this sort of social bubble. And they're like, "Oh my God, what have we done?"
Oh.
And I mean, this kid has not been medicalized, but just being socially transitioned for 2 years, everybody knows him as a girl. And so they were kind of like, "Ugh," but they bit the bullet, and they told him, "I'm so sorry. We've made a terrible mistake. You are not a girl. You're a boy." And he was, as you can imagine, because at this age he's like 6 or 7, he was very angry. He was very, very angry. But he did
I
get
shouldn't
over it.
laugh. This
I know.
is
He did get over
horrible.
it though, and their relationship is stronger now. But it
Okay.
wasn't until the second son, and obviously the second son wanted to be trans because it was cool, right? His big brother's doing it. He's getting all
Yeah.
kinds of attention for it. I want that.
Affirmation.
Yeah, it looks good. And so it was just that experience that like made it so obvious to these women that like, "Oh, wait, 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 wait. That was a mistake."
Dr. Mason, what are the problems that you see with informed consent? That's the next thing I see as a lawyer that's problematic.
Yes, right. I've got a whole paper that I wrote with Evgenia Abruzese and Stephen Levine called "Reconsidering Informed Consent," because and
Mm.
maybe we can put a link to that in your show notes.
Yes.
Because you're right, it's huge. We are doing things to children when they are not capable of understanding the long-term consequences. Like a lot of the law around this was developed around the idea of contraception, of birth control for kids, right? Like teens. And there's law that says that a girl should be able to get birth control without the knowledge of her parents, acknowledging the fact that she may be being sexually abused by her own father. That is a thing that
Mm.
happened. And so
Mm.
we're like, this girl needs to have bodily autonomy. She needs to be able to use birth control, and so they're taking that law, that precedent, and they're saying, well, she also has the ability to decide that she's male and she's going to remove her breasts and remove her uterus, and she has the ability to submit, to assent, to consent to sterilization. But if 20 years ago, if a woman went to her OBGYN and she's like, "I hate birth control. I don't like the side effects. None of it seems to work well for me. I never want to have kids. I am so confident that I never want to have kids. I want you to do a tubal ligation, or I want you to remove my uterus." Um, the the OBGYN's response was, "No, never. We're not
Mm.
doing that. I don't do that for a 25-year-old. I don't do that for a 20-year-old. I don't do that for a 25-year-old." I can't
Mhm.
remember the age, but you had to be sort of like at least 30 and you had two kids, and then you could talk about it.
Well, and reversals of vasectomies are fairly common. People change their minds.
Yes, people change their minds. And of course, what we're doing to the young men caught up in this is we're not doing a vasectomy. We are removing the testicles,
Right, right.
and they're gone.
Permanent.
Yeah, so we're doing permanent surgical sterilization on people who have not even finished developing their frontal lobes and their executive function.
Mm. In talking about the opportunity to reproduce, which children don't value, can't be expected to value.
Yeah.
When I was 24, I was saying, "Oh, I'm not sure I want to ever have children," and I've been thrilled to be a mother. But I just have to read a little bit from Shakespeare. His first 15 sonnets are directed to his beloved, urging that person. We don't know if it's a friend or male or female, but he says, "But thou contracted to thine own bright eyes, feedst thy light's flame with self-substantial fuel, making a famine where abundance lies. Thyself thy foe, to thy sweet self too cruel." And another one, he says, "You had a father, let your son say so." And he talks about having kids with these lines: "Herein lies wisdom." I'm sorry. "Herein lives wisdom, beauty, and increase. Without this, folly, age, and cold decay." He says that nature intended that a person that he values should, or who values themselves, should make copies of themselves to
Yeah.
send into the future because they're so beautiful and so wonderful. Thou shouldst print more, not let that copy die.
Does he really say print?
Yes, he does. Yeah, we've talked a little bit about the standard of care, and that seems kind of I don't know, a bootstrapped uh, standard. But you want to comment on any of the lawsuits, the Tavistock lawsuit, the
Right.
new Kaiser suit that has just come out with Layla Jane as the plaintiff, Harmeet
Right.
Dillon's lawsuit?
So there are multiple lawsuits going on. I think it's important to note that in multiple countries who have sort of socialized medicine, national healthcare, they took a look at the evidence. They did a thing called a systematic review of the evidence, which is a defined term. It's where you state up front what your criteria are for choosing papers, and then you go through those papers and look for bias, and then you look at, then you review the evidence. You can't cherry pick, the successful papers. You have to take them all. Finland did it first, and they did a systematic review of the evidence, and they're like, the evidence does not support this treatment. This is experimental treatment. We're going to back off. Sweden did it next, and then England. So the National Health Service in England, probably responding to the lawsuit of Kira Bell, who was a young woman who had a rough childhood and was a lesbian, and for several years identified as male, and was given puberty blockers and testosterone, and had a mastectomy, and then regretted it. um, and we'll all be grateful to her forever, because she was sort of the first really out detransitioner, in a legal sense.
Mm.
And then the ones you mentioned with Kaiser, I know of two with Kaiser in Northern California: Chloe Cole and Layla Jane, I think. And they both were transitioned as children,
Mm.
and had breast removal as children.
Mm.
And those are two lawsuits going forward. But it is rough because, like you said, in the United States, a malpractice lawsuit hinges on this thing called standard of care. And American medical associations are hanging on to the idea that the only acceptable treatment is affirmation and continuing with medicalization. Um, Norway is now backing away. France is making noises like that. I don't know how long it's going to take for the United States to turn around. If it does, it probably will be via lawsuits.
Yeah, I think litigation is really important here. Um, would you see yourself ever testifying as an expert in something like that?
Yeah, that is probably a thing that is in my future. It's not a thing I look forward to.
No. Have you gotten death threats
But
or any repercussions on your practice?
I have not. I'm very fortunate in that I work in the rarest of things, which is a small independently owned pediatric practice. This clinic where I'm practicing in Gresham, which is sort of a working class suburb to the east of Portland. And my
Mm.
patients, a super majority of my patients are on Medicaid, and their parents are busy with life, and they don't have
Mhm.
time to worry about these sort of elite elite political disputes.
Mhm.
And there are two classes of kids who get caught up in this. There are very troubled kids, kids in foster care, kids with really rough backgrounds that grab onto this like a life ring. But the majority are upper middle class and wealthy kids who are honestly and sometimes just trying to identify out of their privilege.
Yes.
And I don't have a lot of those patients in my practice. And I think
Mhm.
that if I had a family that, saw me quoted in a newspaper article and then called my boss and said, "Oh my God, your doctor is transphobic," he'd be like, "Well, all right."
Mhm.
I'm quite confident my job is safe. But I did have posters with a picture of me taken from the internet put up all over my neighborhood, so these people had figured out where I lived, saying, noted transphobe. And it
Oh,
was
you're
weird
doxxed.
because it said I was an ally for Ron DeSantis, and I've never talked to the
You're
guy.
a self-described flaming liberal,
I
right?
am, yeah. I'm not a big Ron DeSantis fan. I mean, I do think that the Medical Board of Florida was behaving rationally when they said, okay, let's look at the evidence. And they're like, the evidence doesn't support this. I don't think you can maintain your license as a doctor in Florida if you do these unsupported things.
Wow.
But
But
yeah, not a
isn't there
DeSantis
so
fan.
much I'm sorry,
Go
go
ahead.
ahead. Isn't there so much financial incentive to do this? I mean, the old and my husband's a doctor, but the old, adage, the surgeon won't cut on you unless he really needs the money.
Right. Yeah. The surgeons tend to just want to know, like, do I have permission to do this? And do you have money to pay for it? Right. They're not doing a
Well,
lot
and
of,
pharma too. I
and
mean,
pharma too. Yeah. A
these are
Lupron implant.
lifelong protocols of drugs that are needed to sustain a transition, right?
Yeah. A Lupron implant is like 20 to $30,000.
Mm,
And then the testosterone and the estrogen aren't super expensive, but it's the lifelong factor, like you said. It really
mhm.
adds up. There's a lot of money to be made on each patient who is permanently changed and dependent on medication for the rest of their life.
Well, and unfortunately, my alma mater, Vanderbilt, they captured some video of a doctor talking about what a cash cow this was to
Yes, I remember
do,
seeing that.
engage in these procedures. Your relationship with your professional society has been maybe a little fraught. You, it, I've heard you say in another interview that you observed a real flying by the seat of their pants kind of decorum or kind of exhilaration at this new uncharted way they're doing it. Was that did that impress you as the right approach?
No, it did not impress me as the writer coach. Yes, I went to that presentation on pediatric medical transition at the 2019 AAP meeting before the pandemic, and there were three gender doctors, and the room was packed with pediatricians, and the people up on the dais were thrilled. They assumed that the room was full of pediatricians because we were all there because we also wanted to learn how to do medicalization and be life-saving heroes like them. But the
Mm-hmm.
truth was the room was full of pediatricians who were confused and who were trying to get more information to figure out what's going on with this odd branch of medicine. But yes, one of the presenters literally said something like, you can do this too. None of us know what we're doing. We're all making
Oh,
this up as we go along. And it wasn't that it was I have it written down somewhere, but Jamie Reed is a woman who worked at the gender clinic in St. Louis for years and became increasingly alarmed at what she saw happening there. She is also a flaming liberal. She is married to a trans man. And she just saw kids being brought in, kids who had serious issues. The serious issues were being ignored. They were all being medicalized. She saw kids regretting things she had. She had to deal with a phone call from a girl who wanted her breasts back. She
mm.
went through a lot. And in her affidavit, she describes the doctors as saying they are building the airplane while they are flying it.
Oh. God. Let me ask
So,
you a final question as a clinician, just in your own practice. It's so obvious that you love children and love their diversity. Uh, what percent of kids who are in puberty and teenage years are comfortable in their bodies?
I don't
Would
even
it
know.
be
Less than
more than
5.
5%?
I do not think it's more than 5%. Yeah, it is completely normal to hate your body when you're in puberty. I mean,
And at
it's
my
just the way
age
of the
too.
world. Yeah, yeah,
I
people are
struggled.
unhappy. People are unhappy with their body at every age. Actually, when I did that Kaiser interview, there was a woman there, and she said something that really, I don't know, hit me at the right time. We were just chatting. We were just having dinner, a bunch of pediatricians. And she's like, every time I look at pictures of myself from 10 years ago, I think, look at that. I was beautiful. I look great. Why did I hate the way I looked? Why was I unhappy with my appearance? Look at that. But like it takes 10 years and then you look back, and of course you look in the mirror and you're not happy. But
Right.
you look back and that's just human nature. So yeah, we are pathologizing normal puberty. We are telling kids that puberty is optional. And that is crazy.
Oh, say that again. We're
We are
pathologizing.
pathologizing normal puberty. We are telling kids that puberty is optional. And that's crazy.
All right. You are just wonderful. You're just such a credit to your profession, Dr. Mason. Thank you for your time. I know you're doing a million things today that all benefit people, and thank you for taking time to talk to us.
Okay.
Can you tell our audience where they can find you?
Sure. So I'm a board member for SEGM, and our website is segm.org. And there is a lot of information there. If you are curious about this topic, just click on the word spotlight at the top,
Mm-hmm.
and you'll go to a page, and they're in reverse chronological order. But if you just read through the headlines, you will learn a lot. And then if you click on things, you'll learn even more. We have a page of studies where a lot of the studies have been broken down and, explained. So I think
Mm-hmm.
segm.org is a great website. If you know somebody who has a child that's gotten caught up in this, GenSpect, which is GenSpect, and I believe the website is genspect.org. That's another website with a lot of really useful information.
Wonderful. Thank you for your work and for your time today, Dr. Mason. Subscribe and review Conversation Balloons on your favorite podcast platform. Find me at leahfarish.com and on Instagram at LeahFarish.